First speaker is Dr. Mark Menolascino. He's a medical director of the Meno Clinic for Advanced Medicine in Jackson Hole, Wyoming. Dr. Menolascino trained in University of Nebraska and then went on to advanced training at the Mayo Clinic in Arizona. He has a master's degree in pharmacology, immunology, and he was on the heart disease reversal team with Dr. Dean Ornish. I'd like everyone to welcome Dr. Menolascino.
Thank you, George, and I appreciate the opportunity to be here today. I think if you look at the lineup of the schedule of the speakers and the topics, it's really a great lineup. There's actually some information on women's cardiovascular health, which is rare to see. And I think I'll give you kind of a teaser insight of what the future of integrative cardiology is. And as the day goes on, you'll see that it's all going to come together with the last two lectures on inflammatory markers and genetic markers. So I'm based in Jackson Hole, and it's the most beautiful place on the planet. I encourage you all to come visit us. My mission in life is to make food, medicine, the kitchen, the pharmacy, the lifestyle, the doctor. And if we're successful as age management physicians, we provide the tools and the knowledge to empower our patients. We were taught in medical school that we want to motivate people by fear and guilt. If you don't eat this, that will happen. If you smoke this, that will happen. If you drink this, that will happen. I like the idea of providing information and knowledge to empower our patients to help them change their behavior. And some of the things I'm going to show you today is not just the facts and the data, but a couple tools that you can use in your clinic the next time you go back to your office. And I think it's great to have those tools, and it's a very visual type of teaching. Numbers don't really impress people, pictures do. So focus on the dot, try to figure out where you are in this matrix of age management medicine, and you can see how confused your patients are. This is a great example of why the numbers don't tell the story. If you look at those two curves, they're not a whole lot different. And you'll see a lot of numbers today that it's hard to know what to make of this whole cholesterol myth, which is a new book that's out by Steve Sinatra, which is a great read for yourself as well as your clients. Again, I'm a visual guy. I like the idea of looking at pictures. And really, it's all about the intima. That's where all the action is. That's where all the action is going to be. The biochemical insults of the intima, the biophysical insults of the intima. That's really where I think you're going to see the new blockbuster drugs, which will actually be blockbuster mechanisms, are going to be the future of where preventative cardiology is going to go. I used to think when I was naive, before I met Dean Ornish, that your lumen just filled up more and more until you had a little teeny space left, and then a Big Mac came in there and shut it down and you had a heart attack. And that's what most of my clients think. What I tell them is that actually it's when you have plaque rupture, and plaque can be stable plaque or it can be unstable plaque. So not all plaque is bad and not all plaque is good. That's an electron micrograph picture of a plaque. But here's where the action is, and this is a great slide. You're welcome to print it out. That what it's all about, the bad cholesterol, and we'll talk about in the fractionation testing, that creates this plaque. You have a hard fibrous cap, interlumen hemorrhage. You get plaque rupture, which is really the inciting event. So you don't fill up the lumen until there's a little teeny space, then boom, you plug it. You have plaque rupture. Your platelets try to come in. Their job is to fix cuts and holes. They try to fix this little plaque rupture, but they fill the entire lumen, boom, you have a heart attack. That's why you take aspirin. Because aspirin blocks just enough of these platelets so they do this job, but not that job. We're going to talk about CRP and homocysteine, and you can tell people what they are, what the data is, but what does it really mean? So what you want to do is say, if plaque rupture is the problem, the CRP is a measurement of how irritable that plaque is or how likely it wants to rupture. They can get that. That makes sense to them. And then I think of homocysteine as a toxic protein that floats around your body and chews away at this little endothelial layer, again, to make plaque rupture a little more likely. Again, those are terms and those are visuals that your clients can get. Then you can start talking about why omega-3s work. Why does vitamin D work? Why do you want to fractionate your cholesterol? And again, a picture's worth 1,000 words. Well, as much as we were taught in med school, it's not about diet and exercise and blood thinners and cholesterol medications. Yes, you want to be aggressive and manage your blood pressure and your blood sugar. And we're finding more and more that stents and bypass really aren't any better than medical management. And I would hypothesize not any better than lifestyle management. So we're just mopping up the floor, but the sink is running. And again, the more that we go down this road of cardiology and preventive medicine, we're going to see that we have been chasing the wrong thing. I remember in med school hearing that the statins should be in the water, and I'm sure some of you have heard that too. Well, as time goes on, we're finding that those drugs are not as powerful as we thought they were. I still prescribe them. If you're uncontrolled diabetic or you've had a cardiovascular event, there is a role for a statin. As we'll see for the rest of us, there may not be so much, particularly for the women. Now, the U.S. Preventive Task Force, these are the guys that came out a year ago and said, don't do rectal exams, don't do prostate exams, don't do PSAs, because it doesn't change whether they live or die of cancer. And some of my clients have asked me that question, why should I do a PSA? Because the Preventive Task Force says don't do it. Well, that's why they work with doctors like us. Because if your PSA was 2 last year and it's 12 this year, you don't go to your urologist for a biopsy. You sit back with someone you have a relationship and say, well, why is it 12? Did you just get back from a cross-country bike ride in France? Did you have a passionate weekend with your lover? Is there a reason why it's 12? And don't just jump right to a biopsy. So they talked about these non-traditional risk factors, which we're going to mention here, as not really being valid to test. And I think when you're looking at population studies or socialized type medicine, I don't think they are that valid in big groups. But when you look at people as an individual, which is really the beauty of the medicine that you're all doing, is that you're looking at a personalized, individualized, holistic plan, come up with an integrative, functional model that provides good health. Other risk factors, your lifestyle, the central obesity. Dr. Lee was just talking about the adiponectins and adipokines that your central obesity has. Tell your patients that big roll around the middle, which is their cortisol roll. They get that. It's from their sugar imbalance. That's a factory. That's a factory of inflammation. Time magazine a couple years ago, the secret to heart disease, inflammation. What do we think Alzheimer's is? Inflammation. Inflammation is at the root of most bad things. But depression, toxins, anger, hostility, stress, caregiver role, social isolation, their support, purpose in life. Social support, that's why women live longer. They've got a better social network than we do. And then these emerging risk factors, talking to Mark Houston last year, there may be 400 risk factors that you can measure. The question is, what are the relevant ones for you? And that's trying to break it down. Dr. Lee just talked about liver toxicity, leaky gut, and hormone imbalance. I think of true health as food, toxins, bugs, trauma. Or pituitary, thyroid, adrenal, gonadal, gut axis. You've got to get all of those in line. Then inflammation comes down. These emerging risk factors come down. Your social support increases. All of the other things that we have measured for good health. The type A stress behavior, do you know where that came from? An upholsterer in New York City, I believe. He realized that at the cardiologist's office, he kept having to change the arm upholstery on the chairs. And so he mentioned it to his cardiologist, and the cardiologist observed the people that came in and really rubbed the arms. And that's where they came up with this type A stress behavior. Actually, type A tends to do better, but it's the type A that are angry or that have hostility. And that's really the thing to look at in your patients and the thing to share with them. Help them develop ways to deal with their stress, but also to deal with their anger, their hostility, their resentment. Teach them forgiveness, mindfulness, meditation, all of the other things that can help let go of that fuse. So stress isn't all bad. If stress was bad, we'd still be single-celled amoebas. And we wouldn't be at a conference like this trying to get more educated and network and learn more about how to take care of our clients. So again, stress is not what we make it up to be. These emerging risk factors, you start talking to them to patients, and it just kind of goes over their head. That's why I think something like that visual and talking about CRP and plaque rupture and homocysteine chewing away at the cells, that's a lot easier for them to get. But the lipoprotein A, HDL2B, small dense LDL, vitamin D, which is interesting, and then these coagulation factors, 7 and 10, and 2 and 5 as well, too. There's a really interesting, neat hypothesis out, and this is kind of how I tie a lot of things together for my patients. We know that rheumatoid arthritis has a higher cardiovascular risk. Okay? I didn't really put that together until a couple of years ago. all autoimmune disease, there's a higher cardiovascular risk. It's about inflammation. Now they find when they treat rheumatoid arthritis with Enbrel and Humira, guess what? Their cardiovascular risk drops. So maybe that'll be the next statin, $2,000 a week. But what it's really doing is working through this TNF-alpha, one of these inflammatory markers with the inflammatory cytokines just shown below. And here's how I tie food to death. Could gluten cause a heart attack? Absolutely. Could your dairy sensitivity cause a heart attack? Absolutely. So we look a lot at this leaky gut, like Dr. Lee had mentioned, and we look at these food sensitivities. What happens is, leaky gut was something that we walked around with our friends in functional medicine and talked about leaky gut. You couldn't say it out loud because it wasn't a real entity. There's been 3 papers published this year in JAMA, New England Journal of Medicine, and British Medical Journal about this bacterial translocation of food antigens. The hypothesis is that as these food antigens, which can also be bacterial antigens, cross the small intestine barrier, the immune system gets activated. It creates an antigen-antibody complex that can go anywhere. Do you remember the hallmark finding of celiac disease? What is it? What do you see on the skin? Yeah, it's a rash on the shin. So we know there's a mechanism of gut antigen complex skin deposition. Why can't there be one of endothelial deposition, joint cartilage deposition? So that's how I approach rheumatoid arthritis in my practice. Food, bugs, toxins, trauma. And again, chlamydia has been found by chlamydia DNA has been found by PCR in atherosclerosis and in thrombotic plaques. When they grind and bind the plaque that killed somebody with a sudden death heart attack, they find these DNA markers of these bugs. A couple new players, if you haven't heard about these, I'm sure there'll be a couple vendors out here this week that have tests for these. These are very exciting tests. It's the myeloperoxidase and its brother, the plaque. Again, what we're trying to do is you use that analogy of the plaque rupture, the CRP, homocysteine, and you take it one step further. There's a couple enzymes that are released prior to plaque rupture that may be early warning devices for us to find those people at risk. There's a 10 times increased mortality risk if this marker is present. And again, it's just another way to look at inflammation. And when you add it to the CRP, you make the CRP better. I kind of feel the CRP is the gold standard of what I look for in inflammation. This helps me get it more down to cardio-specific inflammation. The plaque 2 test, I love the name because I talk about plaque and it's called plaque, so people get it. Again, it doubles your stroke risk independent of your blood pressure. And so again, these clients that we have that are doing well, their numbers look good, they have normal blood pressure, but their plaque 2 test is high, it catches their attention because they have a twice greater risk of stroke even though everything else looks good. And again, all of these you're going to hear a lot more later today, and I encourage you to join them. I played soccer in London, and when I saw this article, I thought it was very apropos. 25% increase in MI in London the day they lost to Argentina in the World Cup final. So again, and there's probably a lot of hostility and anger stress, not just type A stress in that. Anger and MI, again, 1,600 patients. What happened the 2 hours before their heart attack? Anger increased the risk. You're going to hear more about the genetic profiles. Again, looking at the MTHFR is one thing that I have done for years. They do a lot of activated folates, methylfolate, methyl B12. These tests were unreachable just until recently financially. Now they become very doable, and you can really get some great information and help to personalize your care. Again, this whole genome where we mapped out everybody's DNA hasn't really helped us yet. But these SNPs really do, because you can find genetic knockouts for people, and it's all about food as information. And you can help design plans that utilize the correct nutraceuticals with the correct food-based nutrition plan, looking at food sensitivities, to help develop a personalized plan to reduce inflammation and potential plaque rupture. And if you're preventing plaque rupture, you're preventing diabetes, you're preventing Alzheimer's, you're optimizing hormone balance, because it's all about inflammation in the gut. But we need a better, more personalized way to address this for people. Again, these are called SNPs, single nucleotide polymorphisms. You know, there's a lot of DNA, and we used to think most of it was junk DNA. Actually, these are regulator genes that turn things on and turn things off. And food is what turns them on and turns them off, as well as some select nutraceuticals. Again, the MTHFR with the methyl B12, methylfolate. If you have one of those resistant fatigue patients, resistant depression patients, give them methyl B12 and methylfolate, and good things happen. Yes, you can spend money to do the test to prove that you're right, but an empiric trial for 30 days usually does the trick. Why is this a problem? We're all worried to death about breast cancer. And what I tell my clients is, you know, I can't prevent cancer in you. I can create a situation in the body where cancer doesn't want to live. And that's a pH-balanced, anti-inflammatory, happy body. But we should be able to prevent heart attack and stroke. 2 of the 3 people in this room will die of a heart attack or stroke. And not cancer. But most of our clients are scared to death of the cancer. So if we can work with them to teach them and educate them about how high of a risk we have, then we can actually make a difference. I do a lot of couples consults where they come in together, get their labs, and then it's kind of a team effect. And I say that. I said, 2 of the 3 of us are going to die of a heart attack. Let's make that our first priority. And the beauty is, as we work on that, your hormones will get balanced, your nutrients will improve, your antioxidant status improves, and your cancer risk decreases. Again, half the cholesterol tests fail to identify the people at risk. And most people think they go to a health fair, they get normal cholesterol tests, and everybody thinks everything's great. And as we saw in the first slide, 35 to 50% of people will have an event with a normal cholesterol panel. Again, in the Framingham study, 80% of the patients with events have panels similar to people without events. It's because they are using the wrong test. I'll just quickly go over these. These are fallacies that I really try to get my clients to sit down with me and go through. It's all about family history, right? Everybody thinks that we're doomed because our dad or mom had a heart attack. Well, the longevity study covered, I think it was over 80 years they followed people, including 1,800 identical twins. Guess what they found? They rarely died of the same thing. I have some friends in my town, they're identical twins. The sister died at 75 of Lewy body Parkinson's. She was a heavy drinker, didn't exercise. Her brother just ran the LA Marathon for the 25th time at age 92. They are identical twins. So again, there are some hereditary diseases that you cannot buy your way out of, but it's not doomed by your genetics. The correct diet for cholesterol is low cholesterol, low fat. I mean, I don't like the word diet because the first 3 letters scare me, and they should scare your clients too. There is no diet that works for everybody. There is no diet book that's great for everybody. The blood type, the Atkins, the South Beach, the Ornish. I hope Dean doesn't hear me say that. What does your individual client need? What's so unique? I've got dark hair. She has blonde hair. I've got dark eyes. She has blue eyes. We're genetically very different. My biochemical needs for B12 may be 1,000 times higher than yours. And if we can look at this biochemical individuality, how it bays over our genetic uniqueness, then we can start getting a plan to personalize care for prevention. And lowering cholesterol is not the main way to reduce heart disease. It's inflammation. And again, it's not rare in people with normal cholesterol. And again, paint by numbers medicine is what I was taught in internal medicine. You know, I went to internal medicine because to be a functional, integrative, anti-aging specialist, I thought you wanted to do internal medicine so you got all the great training. Well, I did critical care, I did all the specialties, and that was back when it was unlimited hours. The year I left, they cut it to 80 hours, so I got a third more training because we did 120 hours a week. But I wanted to be able to stand up here and quote to you the latest double-blind, placebo-controlled, randomized, multi-center meta-analysis trial that stated this. As time has gone on, as much as I want to be evidence-based, I found that the evidence-based medicine is not what we were told it was, and I'll show you some data on that. I'm more interested in what's unique about you. What's your lifestyle? What's your belief system? What's your spiritual beliefs? What are your weaknesses? What are your strengths? What's your support system? How do we tap into all that to get you healthy? Again, the myths of cholesterol. If my total and LDL are normal, I don't have to worry about it. That's not true. If I exercise and eat healthy, I don't have to worry about it. Women aren't as susceptible to heart disease as men. Again, women, you've not been taken well care of in medicine because we don't do clinical trials on women, we do them on men. The routine test does not give you an accurate measure, and if my HDL or good cholesterol is high, I'm more protected. I can't tell you how many people come to see me and they have a high HDL with a high total cholesterol, and they're told because the ratio is under 3, they're okay. You know, and the high HDL is interesting. How many of you have seen women with an HDL in the 80s, 90s, 100s, 110, 120? Well, I see that, and she'll say, well, I do Pilates every day, or I run every day, and so I should have a high HDL. Well, that's not exactly the case, and there's a couple theories about that. Dean Ornish talks about garbage trucks, which I'll show you, that if you got more garbage, you need more trucks. So I'll see, again, a woman with a cholesterol of 280, but she has an HDL of 110, and everybody's blowing her off. Well, we look at it, and she's got high, small, dense LDL. She's got high lipoprotein A. She's got high CRP, high homocysteine, high plaque-2, high MPO. The woman's a time bomb. In Jackson Hole, we're probably the fittest group of people on the planet. But around us in Wyoming, Utah, Idaho, we have a group of very unhealthy people. They've been slowly migrating their way to us because they're not doing well with the traditional medical care. And they're willing to spend 2 hours to sit with me and learn about all of this. Then they go back. 3 months later, they go to church and their pastor says, oh my gosh, do you have cancer? Because you look so thin. You've lost 150 pounds. And they'll say, no, I went from a size 18 to a size 8, and it's because I'm exercising, eating right, and taking care of my life. We also have very fit people who have dropped dead skiing. In the last year, we've had 3 people have major events while skiing, and they were recognized by the community as the fittest people in town. And guess what they had? Normal cholesterol panels at our health fair. But no one had looked further. I would suspect that some of the markers we're going to talk about were high in them. So, you know, the dietary risk factors, yes, calories, low nutrient dense, the sodium-potassium ratio, your acid load, hydrogenated fats, the glycemic load, ORAC value, which is your antioxidant score, and then it's really all about the bad fat. Again, the traditional cholesterol testing, cholesterol, LDL, HDL, triglycerides, it's a calculated value, and you cannot trust it. So this is a slide that I show my clients, and that how it's a lot more complicated than what you were led to believe. There's multiple particles, and I show them actually a picture of a particle of an NMR lab report that shows the different particles. The 3 particles for HDL, the 4 for LDL, as well as the different patterns. Again, this is a pretty powerful slide for them. The test I'm going to do is the one on the left. The one you got is the one on the right, and we calculated what we think is your real risk. The advanced cholesterol testing is maybe up to 90% predictive versus the old, and again, that catches people's attention. There's multiple companies that are out there that do it. I like to show people results before I actually do the test. I tell them what we're testing, what the results are going to look like, what some of these particles mean. And, you know, people have to hear things 3 times to actually get it. And you've got to really slow it down and show them some visuals and make it in a way that's a story that they can get. This is one of my favorite handouts to give my clients. And so, you know, this is the old-fashioned way to look at your risk. We all were told it's about LDL. And when you get your LDL, it's calculated. So when you fractionate it out, the total LDL, when it's calculated, doesn't tell your story. These are the small sticky marbles, the big bouncy basketballs, and the small sticky marbles with a nasty tail on them. Again, people can get that rather than talking about what they actually are biochemically. Now, if you look at this, statin resistant for lipoprotein A, a very resistant particle. I'm not sure. Are a lot of people checking LPAs? How many have had success lowering it? Yeah, let's see a couple hands doing this. It's a tricky one. Linus Pauling had talked about high-dose vitamin C. Now, I think Linus Pauling was doing 10 grams a day of oral vitamin C. Has anyone tried to take 10 grams a day of oral? It's impossible. But he talked about lysine, proline, carnitine. And there's some products out there that I've had some marginal success with it. But lipoprotein is a pretty tricky particle. But again, I tell them small sticky marbles, big bouncy basketballs. The statin drugs don't really get these that well. They get your good ones. So yes, your total LDL will go down. Sorry about that. Your total LDL will go down, but it may go down at the sake of the ones that you're trying to preserve. And just as a basic, you want Good large buoyant, good triglyceride and HDL, that'll lower your risk versus a small dense LDL, triglyceride, and decreased HDL. But it's much more complicated than that. But that's where I start with people. I show them the slide of the LDL fractionation and tell them what we're trying to do with these two things and stop there. They can get that. Show them the picture of the plaque and how it ruptures and why you're worried about CRP and homocysteine. Start there. And by using those markers, you at least get a foothold and you get provided them with information to empower them with knowledge to change your behavior. Again, of course, you want to exercise, lose weight, stop smoking. In my practice, you can't come back unless you at least make a contract to quit smoking. Because if you're smoking, I can't help you. There's no intervention that I can do that can outweigh the damaging effects and oxidative stress of smoking. So we sign a contract that they're at least going to pick a date and make an attempt to quit. And I don't think I've failed yet. The other trick I've done is I'll tell them I'll give them half off their visit if in 6 months they have quit. If they don't, then they have to pay it back. Omega-3s, plant sterols, red yeast, rice, niacin. We're going to talk about all these in depth too. So, you can't always trust what your doctor says. More doctors smoke Camels than any other cigarette. And I remember when I was a kid and I went to the pediatrician, he was smoking during my consultation. And it's just boggling. But maybe this is where we are now. Maybe this is where we are with some of our medications, where we are as ignorant about the dangers of some of the things we're using as they were about the dangers of smoking. Like Avandia. How many people prescribed Avandia? Okay, it's banned in Europe. This number of 47,000 deaths, I think, is up to 70,000 deaths. It's still available in the U.S. with a black box warning. But here's a drug, this is a diabetes drug. We're using a medicine to treat a disease that we're worried about will cause a heart attack. What did these people die of? Heart attacks. So again, the model's broken and we need to find a new way. And I think what you're here for this week, you're going to see those new tools in a new way. The problem is your clients are figuring this out because it's now in the popular press. And so it makes our job a little easier. All of my internal medicine friends, when I was doing training, I knew there was a problem with these. When I did my master's in pharmacology, we were looking at treating Alzheimer's with Vioxx, and the pharmacist said, bad idea, because that's going to affect the prostaglandins, which will increase your endothelial rupture risk. Guess what? That's exactly what it did. So this is an older Business Week from a couple years ago, and this is another slide that I show my clients. If there's two people in the room that have pneumonia, and I give you both a Z-Pak, and one gets better, one doesn't, the drug's 50% better than giving you placebo. So when you see these 30%, 40%, 80% better, that means really nothing. The number you want to look at, and I hated statistics, but this is easy for me, the number needed to treat. That's the bottom line, guys. And you don't see that much in your journals. And you definitely don't hear that on the TV commercials. But how many people do you need to treat for how long to prevent a problem? It's interesting because if you look at the first two, for H. pylori, you only need to treat 1.1 people to eradicate the bacteria. But you have to treat 5 to heal the ulcers. So that PrevPack that we're taught fixes H. pylori, will prevent an ulcer. It only does it in 1 of 5 people. So that's the uniqueness of the biochemical and genetic individuality that one person will benefit, but it's going to take 5 to heal the ulcer completely. Now these numbers have been bantied around a little bit and they keep changing. I think the current one I saw was 267 men for 4.7 years to prevent 1 cardiac event. Now is that a lottery ticket you would buy? That's a lot of patient years, and 1 in 10 of those will have a side effect that will force them to stop therapy. And again, these are numbers that I point out. I teach them this idea about number needed to treat, and that the percents you can't really judge. And again, feel free to print a couple of these out and have them in your office. They're just great teaching tools for your clients. So in people without heart disease but have high blood pressure, it's 70 to 250 to prevent 1 heart attack or stroke. In people without heart disease that have high blood pressure, over 500 prevent a death. And again, in most clinical trials, there's not enough significant reduction of deaths to even actually calculate that number. So there's a lot of discrepancy about whether you can trust these numbers you're hearing or not. And I hate to be a cynic about a lot of things, but again, wanting to be an internist, be able to quote the latest studies, I think I've really lost a lot of faith in that. I still think you need to read the literature, be abreast of it. There is good medicine going on. But even back in '78, the Office of Technology said no more than 15% of medical interventions are supported by reliable scientific evidence. The editor of the British Medical Journal 10 years later said maybe only 1% of the articles have scientifically sound treatments. David Grimes in JAMA said much, if not most, of contemporary medical practice still lacks a scientific foundation. So when you're treating someone with a TSH of 2.7 that is cold, tired, and overweight, and you're a little wondering, gosh, that's not maybe standard of care in my community, that's not what the guidelines I was taught in medical school, have a little confidence that you can trust your intuition, push things. The thyroid's a great example. I can't tell you how many people, particularly women, I've taken off antidepressants and cholesterol drugs by fixing their thyroid. I shoot for a TSH of 1, and Dr. Lee talked next door about not getting a suppressed TSH, and I think he's right. But shoot for a TSH of 1. The new guideline is 2.5 or 3, depending on what society you believe. And if you don't have the furnace hot, you won't burn the coal. People get that. So if you don't have a thyroid that's optimal, you'll never get good brain health and you'll never get good cholesterol support. The biggest indictment was Marcia Angel, who's the former editor of New England Journal of Medicine. It's simply no longer possible to believe much of clinical research. So again, take it with a grain of salt. Do read it, do stay abreast, but don't always not treat someone because of some study. Simvastatin's a great story. In 2004, there was a JAMA article about how well it worked. What they did not publish was that it caused muscle damage in 61 of 1,000 people, where it was originally reported as 8 per 10,000. Simvastatin is no longer allowed in Europe at 80 milligrams. It's no longer recommended to start at that dose in America. They do increase the risk of diabetes, dementia, and depression. There's an FDA black box warning. Have you had one of your clients bring in a pill bottle recently from the pharmacy? Well, they don't get the black box warning. They just get the plastic pill bottle that doesn't have all the information anymore. Most of your clients do not know this, and it's absolute truth. There was a 9% increased risk of diabetes in a meta-analysis done by Lancet. And I've seen this a lot in my clinical practice, where people have blood sugars that sneak up a little bit, and they're doing everything else right. We take them off their statin, put them on reduced rice, and their diabetes goes away. The Jupiter study is another one of those that I was really proud because I knew all the data for. It may not have been a great study. They may have stopped it too soon. There was an increased number of deaths in the placebo group, but maybe not a significant number to really come to the conclusion. But they were looking at CRP and found a reduction, again, of 44%. And the conclusion was maybe we need 40 million more people on statin drugs. Well, it is about the CRP, but there's better ways to do it. It's probably your single strongest predictor of cardiovascular risk. It's the inflammation of that plaque in that wall like we talked about. And I'm going to go through some of these kind of quickly. You can go back to them. They're good references for you. Again, it increases the association of heart attack and stroke and cancer. Okay, remember inflammation, cancer. Homocysteine, it's an amino acid, toxic to the artery wall. That sounds great, but show them the picture and point it out and tell them what it does. Again, independent for heart disease and Alzheimer's. There's been several studies. Initially, there was a lot of support for homocysteine in the cardiovascular literature. That's somewhat waned. In functional medicine, this is a measurement of methylation. Methylation may be one of the roots of all evil. And if you're not methylating, you're not going to be healthy. Again, cancer, Alzheimer's, heart disease, multiple other things. What's interesting, too, we're just talking about methyl B12. A lot of these studies did not use methyl B12 or methylfolate. So if they had MHTFR genetic knockouts or SNP polymorphisms, see how this all ties together? Then maybe those people were not responders, but they didn't look at it. There's a couple slides in here about nutritional studies and how to really be careful about what you're looking at the data, be a little bit careful. Vitamin E is a great example. Vitamin E, there's 3 kinds. Alpha, gamma, delta. Most of the studies have been done on alpha vitamin E because the people doing them didn't know anything about nutrition. Alpha vitamin E does not work, and it blocks the activity of gamma and delta. So again, it's a lot more complicated than just introducing the nutraceutical. Go to the magic of food. This is Dr. Vogel that did brachial artery implants looking at vasospasm, gave everybody a Big Mac and looked at the vasospasm in 45 minutes up to 6 hours later, and there's a huge change in the arterial vasospasm. I have a lot of my patients say, oh, I just had a huge steak, and as I was walking in the car, I got some chest pain. I had to take a nitro. And you'll hear that too. Food is medicine, but really food is information. The information turns the genes on and off. The Mediterranean diet, well, we knew this in 2004. Now, they just published another study that proves it, but it lowers all-cause mortality. And if you were to pick one diet for your clients, that's really the one. The biggest thing about it is it's fairly low in dairy and very low in processed foods. Again, Alzheimer's, heart disease, I see them as the same thing. This is some interesting mouse studies where they looked at a genetic mouse that was high-risk cancer, diabetes, and obesity, gave the mothers methylating agents, methyl B12 and folate choline. These are genetically identical mice. Every offspring should look exactly the same, and they don't. Lower risk of cancer, diabetes, and prolonged life. Well, I live in Jackson Hole. I have a mom moose that lives in my yard every summer, so I did my own methylation study. This was 1 year, and so the next year I fed them methyl B12 and methyl folate, and look how much better their coats are. No, I didn't actually do that. Calorie restriction. Denham Harmon was at Nebraska and I was there, father of the free radical, and he believed in calorie restriction as the answer to all life. I think he lived to 90. 2 monkeys, one's calorie restricted, the other's not. Big difference in how they look and affects their biological age. And then, as you get to these supplements, has the medication had any other side effects? I think supplements are medicines. And what you don't want is someone to come in taking something that is poisoning them or interacting with their medication. 22% of pre-surgical patients are taking herbs. Doctors don't ask. Some advanced centers are, but they don't really know what to do with the data because the pharmacists are not taught this. Again, these are some interactions for you to be aware of. I'm going to move through them for you. When I was at the Mayo, we had a woman that had a bypass and they couldn't get her to stop clotting. And I talked to the husband and I said, is she taking any vitamins, any nutraceuticals? She's taking 20 grams of fish oil a day. And that was probably what was blocking her clotting cascade. They gave her activated factor 10 and it stopped. Licorice and hypertension, I see that a lot. And ginkgo and coumadin, I'm not sure if that's on there. Ginkgo and coumadin as well as glucosamine and coumadin. So those are 2 really common things you'll see a lot. Now, so when we talk about herbs and nutraceuticals, we all kind of like to see pictures like this, and we see the beautiful herbs in the raw form. But this is what I see in my office. People come in and they bring a shopping bag or a suitcase. What does this do to your liver when you take all of these pills by mouth? It's a huge stress on your liver. And a lot of times we'll take supplement holidays. We'll just tell people, go off everything for a week and come back. And let's see how you feel. Most people feel better. Then we start over. And then the quality is huge. If you look at some of the things on this table, I encourage you to use pharmaceutical, medical grade supplements and talk to your vendors here this week. There's grocery store quality, there's health food store quality, then there's medical grade. It's a huge difference in what you use. One of my first clients I gave melatonin to, they went to the grocery store and got it, didn't work. They came to my office a year later and got the medical grade, worked like a charm. But now melatonin works on 50% of my patients. 10% of them get hyperactive from it. And so again, it's a real art of using these supplements. They're not Lipitor that does the same thing to everybody's LDL. It's a real synergy, and sometimes you can combine things in a certain way and get a real synergistic response. This is one of America's most popular vitamins. You guys all know it by name, I'm sure. There's 7 toxins in it, by the way. So when you look at a vitamin, have your clients bring them in, turn it over. Look at the ingredients in it, but look at the other ingredients. Look for FD&C yellow aluminum lake number 6. Look for the titanium dioxides. Look for the things that you can't pronounce. But if there's more things in the other ingredients than they are in the real ingredients, it's a bad idea. It should say gelatin capsule only. The problem with Americans is that they want a simple answer. An escalator, are you kidding me? But they want a pill for the ill. That's what we have brainwashed them with all of our commercials. A pill for the ill. Again, I'm a fanatic about sugar. It's interesting to see how much sugar is in the chocolate milk and the regular milk. But sugar is an evil. And I tell people about alcohol. I have a picture of a wine glass that's half full of sugar sitting in my office. And so when people ask me about alcohol, and I say, well, the studies say a glass of wine seems to be good for you if you're Italian living on the Mediterranean. We don't know about an Italian living in Jackson Hole. But the data is kind of confusing about alcohol. I'm a doctor of moderation. I think have a glass of wine, but drink really good wine, do it with your lover, and make it passion. Again, get at that spiritual connection, that relationship connection, that social support. But if you're coming home and you're reaching for a scotch to cover the stress of your day and it ends up being 2 or 3 or 4 scotches, then we have a problem. It's all about the glycemic load. Glycemic index and glycemic load are the key to help teaching your patients about eating good whole foods. High blood sugar spikes insulin. Insulin is the most inflammatory thing in your body. It creates insulin growth factor, which we've got to be a little bit careful with. And poor diet can be a factor in disease. Again, the food you eat regulates your genes by this new concept of epigenetics. And it's very interesting how food can turn things on and turn things off. But they do it for different people different ways. Again, just a couple pearls about watching your clinical trials. Not using the right type of supplement, a high enough dose, the antioxidant mixtures. And we'll go over a couple. Here's the vitamin E data. It's all over the place. And then this is some of the things I just want to share with my personal experience in using nutraceuticals. Red yeast rice extract has been a boom for me. But some of the grocery store and health food store red yeast rice, they have lovastatin in them. Okay, so there's some companies that are spiking their supplements with a statin drug. So they work, but you're essentially getting the same problems as a statin. I'll get people come in and say, I can't take that red yeast rice because it made my muscles hurt. And I'll look on consumerlabs.com, which is a great way to look at the quality of a nutraceutical and see that that's been shown to have lovastatin in it. This is a wild, wild west. They're not regulating it. So look for companies who regulate themselves. Their quality, they analyze the batches pre and post, and are doing good medicine. Omega-3 has been beat up a little bit lately. I love omega-3s. I've seen fantastic things with it. But it's one of the most toxic vitamins you can buy at the grocery store. Because if you're doing industrial remnant fish parts from Central America or you're doing small North Sea fish, it's a huge difference in the quality of arsenic, mercury, and toxicity that you're going to get. It has multiple great benefits. The Italians showed that it reduced all-cause mortality and sudden death after an MI. Again, one of the most powerful things you can give someone post-MI. The Japanese also did a great study, nice N, and again showed a marked reduction when you added the EPA to the statin drug. Again, red yeast rice, it's the monocolin K, that's the active ingredient. And you get a synergy when you combine it with the omega-3s and things like the sterols, and you get great numbers. This is one of my favorite studies, the simvastatin compared to the Mediterranean diet, fish oil, and red yeast rice. This is what I do in my practice for my clients. I get a 90 to 95% response rate. I mean, dramatic cholesterol lowering. Again, it lowered it 42% versus 39. I mean, essentially the same. CPK, heartburn versus myalgia and elevated LFTs. Again, statin-associated myopathy. I get a lot of consults for people who failed statins due to the muscle pain. And this is one of the tricks that I've used is switch them to the red yeast rice. Vitamin D, I think there's a study that was just published on adding vitamin D in patients who are low normal. And vitamin D, the range is 30 to 100. I want you 60 to 70. And so in those people with low D, when we supplement it, they actually get a better response than when they don't. Niacin's all over the place. I've had one person actually pass out from niacin. It causes a flushing. I tell people, take niacin at your dinner. Not at bed with an aspirin, take it with your dinner. And if you eat a spicy meal or have more than one glass of alcohol, don't take it that night. Again, the recent study, they stopped because there was no benefit. And again, it may not tell the whole story about looking at one thing. Soluble fiber, again, you can take oats and psyllium and pectin and guar gum. Just eat your fruits and veggies. Get your fiber in your intake. Let it be food as medicine. Most people don't like too much fiber. The plant sterols, another one of those things where the brand makes a huge difference, and the brand in different people makes a huge difference. So I've had mixed results with sterols, and it seems like if one cocktail doesn't work, I've got to pull one thing out and kind of switch them until we get the right connection for that person. Google Lipids, an Ayurvedic remedy. When I first started using it, I had really great results, and now I've kind of had mixed results using the same supplement. I'm not quite sure why. Polycosanol is an interesting story. The European studies showed benefit because they had access to the Cuban source, which is a sugarcane derived. We use the honeybee wax derived. It doesn't work. So a lot of what you buy in the U.S. in polycosanol, I've not seen good success with. Interesting, the Cuban one also has a Viagra effect. Again, just some of the numbers on the polycosanol, and I apologize for moving through these slides. I kind of wanted to give you the clinical pearls, not so much the data. Garlic, there's one brand of garlic, a brand name that's shown really good evidence. Unfortunately, it was in their own trial. I've seen mixed results with garlic as well. Soy, I'm not a big fan of soy because 97% of it is GMO produced. It's an estrogen modifier, but has shown some benefit. Antioxidants, again, have been beat up, and it's all over the place. And I just don't think we're going to get a study that's going to be able to do one thing for one person and not control for everything else. There was an increase in heart failure in that group as well. Again, some study limitations that you'll see in all of these. Vitamin D, check them in all your patients and get it to 60 to 70. You'll see good things happen with your immune system, with your mood. The biggest one recently is calcium. Does it cause heart disease? The key to this was it was a subgroup analysis. It looked at people who only took calcium. You've got to add magnesium because magnesium is a calcium channel blocker. It prevents the toxic effects of the endothelium of calcium alone. Again, I'm just going to move through this data. And just to close, the fight or flight response, you put toxicity with stress and hormone imbalance and nutrition and toxic environment, no wonder our clients are sick or tired of being sick and tired. Thank you for your time.